This is Intention to Treat from the New England Journal of Medicine. I'm Rachel Gottbaum. Today we're talking about the explosion in childhood obesity and diabetes in this country and the use of the newly approved GLP-1 agonist medications in kids.
My name is Laura, and I have a 14-year-old daughter. We've been battling with obesity since she was a baby. I guess you could say that we've always had an issue with food. When she was a baby, she would finish her sister's plate, and we didn't really think a whole lot about it. But then we noticed that she was getting heavier and heavier, and we would go out to dinner, we would come home, and she would throw a tantrum because she wanted another snack. When she was around kindergarten, we did take her to a therapist, and he helped us with delay of gratification. That really made a difference for her behavior. So she no longer was throwing a tantrum to get food, but that didn't stop her from wanting to eat. And she continued to overeat. We would go to the doctor every year, and they would say, she's off the chart. You should probably talk to a nutritionist. And we did. We did talk to a nutritionist, and I felt like we were doing the right things. They say, do you drink juice? Do you drink soda? I'm like, no, we already aren't drinking juice and soda. We're already drinking lots of water. Yes, she has milk, protein, vegetables. Eat less, move more. We were doing all of that, but it didn't make a difference. She just continued to gain weight year after year. So when she was 12 years old, I kind of just reached a breaking point where I felt like I was not helping her at all. So I took her to the doctor. And it was the same conversation. What kinds of foods are you eating? How much exercise are you getting? So between that first appointment and an appointment 1 year later, she gained another 25 pounds. She's 5'10" and 250. She's not able to keep up with all of the other kids doing the activities and the sports and chasing after boyfriends and whatnot. You know, she's left out. And people don't have to verbally pick on her for her to feel bad about herself. She wears long sweatshirts every day, even when it's hot. Like she's hiding. It is impossible for her to even have a conversation about her weight. As soon as I bring it up and I start to ask questions, she just shuts down immediately. She won't talk about it. She gets teary. She walks away. I know that diabetes is lurking in there. Diabetes and obesity both run in my family. I know it's coming. It was decided that we should probably test her for diabetes, and we scheduled the glucose tolerance test. She's not diabetic, but she has insulin resistance. If your number is above 200, you have diabetes. She was 196. So even though she's technically not diagnosed with diabetes, I know we're right there. But that made it hard for us to get treatment. The doctor suggested that we look into one of the injections, medication. So we did start the medication in January when she was 13. But because she wasn't diagnosed with diabetes, they had to prescribe her a certain brand that was just for weight loss, not for diabetes, because she technically wasn't diabetic. Well, that is not covered by insurance. We made the decision to just go and pay for it ourselves. $1,000 a month for this medicine because we couldn't get it covered. My daughter's been doing the injections for 4 months, and She has not gained any weight at all. So that is a win. That is a huge deal for us. The other thing is she had her fasting glucose test done and it dropped to 80. We're hoping that this medication is going to help her live a long, healthy life. And so far, the medicine is helping us not become diabetic. But so far, the insurance will not cover the injections for her. So we are spending thousands of dollars on this medicine. And I'm just hoping that this medicine is going to make a difference for her.
This is Intention to Treat from the New England Journal of Medicine. Now we're joined by two doctors who work with kids struggling with obesity every day. Dr. Awab Ali Ibrahim is a pediatric gastroenterologist at Massachusetts General Hospital. And Dr. Tamara Hannon is a pediatric endocrinologist and director of the Pediatric Diabetes Program at Riley Hospital for Children in Indiana. So, Dr. Hannon, I'd like to start with you. Let's talk about this issue of pediatric and adolescent obesity. What's changed and what are the most active areas of concern?
I've been a pediatric endocrinologist now for 20 years, and at the beginning of my practice, I had very few patients with type 2 diabetes, not because it didn't exist, but it was quite rare. And really over the past 20 years, it's become more common. We have hundreds of patients in my clinic with type 2 diabetes. That's really the most remarkable thing that I've seen change. What's changed in the treatment of increased childhood and adolescent obesity is that we have much more evidence about what is effective, and we have pharmaceutical agents that are available, and that's different. Just in the last few years, we have some really effective agents.
Dr. Ali Ibrahim, you work in a Boston clinic with a large Latino population. What are you seeing with your young patients?
Diabetes is only one of the many conditions that we see with obesity. In my clinic as a gastroenterologist, I see a lot of what was previously called non-alcoholic fatty liver disease. Now it's metabolic dysfunction associated liver disease. And that's becoming one of the major causes of liver transplantation in the United States. And we know obesity predisposes to this condition, and taking care of this very early on in life is going to decrease the chances of that liver transplant happening later on. But again, a lot of insurance companies don't see that. They don't look at that picture. They might look at just weight without looking at all the other things associated with that increased weight gain.
So what's going on here? Why this explosion in diabetes and obesity in kids? 1 in 5 children are obese in this country, with the same number vulnerable to developing diabetes. And those numbers go up for Black and Latino kids.
We eat differently. In the past 30 years, the kinds of foods we eat have changed. The availability of food has changed. And then there are such economic disparities in availability of different foods that we would consider nutritious foods. I grew up on a farm in the 1970s where we had a large garden. Most of our foods were scratch cooked. That was the usual. That is very, very rare now. And now our bodies consume a lot of sugary beverages, highly processed foods in the form of snack foods, cookies, cakes, foods that release sugar into the bloodstream very, very quickly. Without a delayed process of release of sugar, your body makes a lot of insulin. You develop insulin resistance from eating and drinking too much sugar. You develop excess body weight from that. And there's a hormone response that's absolutely different than when you eat whole foods, balanced macronutrients all together as a meal versus as snack foods kind of all day long. I hear a lot from parents that, their child just can't stop eating. Some of the foods that we're talking about actually switch off your ability to tell whether or not you've actually eaten a lot of calories or not, because they're hyper palatable, such that you want to keep eating, you want to keep eating, you want to keep eating because they light your brain up, right? Your brain's not going to turn off and say, I'm full with a lot of the foods that we eat the most of today. And people who make these foods, they know it.
And socioeconomics have a huge role here.
We know that Black and Hispanic children have the highest rate of obesity. And we know as these children grow, Black women have the highest rates of obesity in adulthood. And we know that Black men have the highest rate of obesity-related comorbidities in adulthood. Now, a lot of this happens, there's multiple reasons. Food insecurity, a huge factor. When you're food insecure, you're unlikely to get healthy, nutritious meals. Lack of access to healthcare providers with training in obesity medicine. Again, this might not be an issue here in Massachusetts, but where I trained in areas like, for example, Mobile, Alabama, or the Deep South, that might be a big concern down there.
So let's talk about how you're using these GLP-1s in your practices. Dr. Ali Ibrahim, I'll start with you.
I don't want to jump straight away to medications. I want to look into their dietary history, see if there's something I can fix. Discuss their lifestyle, discuss their dietary habits, discuss their stressors. I always want to start with lifestyle therapy. That's usually my initial approach. But we know that that doesn't work with everyone. We should always start with lifestyle changes. If these are successful, great. If these are not successful, then we do have to resort to other therapies, including the GLP-1 agonists that we have. We know that childhood obesity is associated with increased risk of obesity in adulthood. We know that obesity is associated with over 200 chronic conditions. And we can't just wait for the kids that we take care of to develop these chronic conditions and then start treating them. We have to have a preventative approach.
Dr. Hannon, maybe you can weigh in also on how you use the medications with your population in Indiana.
There are a couple of things that we address with everyone, and ours happens to be sugar-sweetened beverages, because we have found and we know that those are directly related to excess weight gain. I would say always, if someone's drinking a lot of sugar and then they decrease and stop that, that is very, very impactful. So in our clinic, we start with that. And we start actually with family-based treatment. So as much as possible, eating meals together, regardless of what they're eating, having a meal together is where we start. And I start with lifestyle as well. Medications can be very, very helpful. And in Indiana, the GLP-1 receptor agonists are not covered by public insurance. And they're not covered by private insurance in children in the vast majority of the cases as well. So even though that's something that I would like to use more, effectively I can't, because families cannot get them.
So let's talk about access. Earlier, we heard from a parent whose daughter is obese and facing diabetes. This mom says they've done all the lifestyle changes they can do, and medication is the only thing that is offering a glimmer of hope. But they can't get insurance to cover it, so they're paying out of pocket. Why is it so hard to get coverage for kids for these GLP-1 medications, especially if we're seeing such a need?
A lot of this comes from the fact that obesity is not considered a chronic disease. It's still considered like a lifestyle disease, something that you can just take care of with a diet and lifestyle. And the understanding of obesity as a chronic disease is not yet developed in the medical world in a lot of healthcare systems across the United States. So when insurance companies look at this cost effectiveness, they look at 1, 2, 3 years out from when starting the medications. Again, it comes to the fact that they are not considering obesity as a chronic disease.
I mean, that's what drives me crazy. Let's say I have a 14-year-old patient with pre-diabetes, with multiple family members with diabetes. And this person is on the brink. You know, she's almost at the cut point of having diabetes. And yet I can't treat her with an effective agent until she actually gets diabetes. And no pediatric endocrinologist would say that that is cost effective to wait until someone has diabetes before you treat them. It doesn't make a lot of sense to tie the hands of the physicians for effective treatment options. It creates a lot of disparities. And some families who have the finances to afford these medications are getting them. Those who do not are not. These medications are FDA approved for use in adolescents who meet criteria. So the reason they're not being covered is because they're very expensive. But that's the only reason from my point of view why they would not be covered.
So there's a lack of access, but there's also a lack of data in kids. What are your concerns about giving these medications to children?
There are risks with every treatment that we do in medicine. So, for instance, in the GLP-1 receptor agonists have a warning about thyroid cancer because there is an increased risk for thyroid cancer in rodent models. There are also risks for rapid weight loss in general. So, for instance, rapid weight loss is associated with gallbladder disease. We know that. We've known that for a long time. And we see that with these medicines on occasion as well. And the other thing is pancreatitis, inflammation of the pancreas, infection of the pancreas. It seems that these medicines may exacerbate that. The other risk that I see and that I think about a lot is that when you start a medication and then you suddenly don't have access to that medication, you can have weight rebound, which is morally devastating. It's hard on your body to weight cycle. And so that's a real concern in the United States where access to these medicines can come and go. We have shortages of these medicines. They're very expensive. So I've had patients who go on these medicines as part of clinical trials. And then when the clinical trial is done, they can't get the medicine anymore and they regain the weight.
Dr. Ali Ibrahim, your concerns?
Weight loss in general, you have some lean mass loss with any sort of weight loss that we do, whether it's through medications or not medications. Now, in a growing preteen or teenager, when we're putting them through a catabolic state, a state of breakdown, whether it's adipose tissue breakdown, whether it's lean muscle breakdown, what is going to happen to them in the future? Especially if they continue being on this medication for decades. These are chronic medications. They're not meant for use for short-term use. Once we start them, for most people, they will have to continue on these medications for the rest of their lives. Now, how is that going to affect them in the future? And I do worry about overprescribing these medications, especially as they get cheaper. Many of us are not trained in nutrition. We're not trained in exercise physiology. So it is very easy for someone who's not trained in these two things to quickly jump to the medications. They'll take care of your obesity. But is that the best thing to do for a patient? I don't think it is. I think lifestyle should always be at the center. And based on a comprehensive review of all the data that we have in meeting the patients, then we can decide on what's best for this patient. We need to create a tailored plan for every single patient. And it can't just be, oh, you have obesity, we're going to prescribe a medication for you to take care of that problem. And I worry about that trend continuing to increase.
And what's currently understood about what these drugs mean for children's mental health?
I think that's very, very important. I've just had a patient last week who I started on a GLP-1, and she was telling me that food does not hit the same anymore. Now, for a lot of these patients or a lot of the people I see, food or having a meal is the best part of their day. This is what keeps them going. And now I'm putting them on a medication that is making that less enjoyable. And I do not want to take that away from them because we know that for many that can predispose them to eating disorders, to other mental health problems.
What I'm worried about is related to the loss of pleasure. There's something that is coming out that is quite worrisome in the bariatric surgery literature, and that's the use of other substances. Alcoholism, substance abuse, kind of replacing food in a way. There is evidence of this in literature of kids who have lost a lot of weight as adolescents. And so I worry about those things as well.
There seems to be a lot of stigma around weight, especially for children and teens. How do you counsel clinicians about this?
A lot of patients feel stigmatized by their primary care provider. They don't feel comfortable. I had a patient tell me last week that she does not like talking about her weight to doctors because she thinks all doctors are fat phobic. She feels judged when she comes to the office.
Your words matter. And the person sitting in front of you is a child. And I've seen many, many patients who were told by their primary care provider or a family member who used disparaging words about them, called them lazy, called them fat, used the word obesity to describe them. And you can see visibly the person just shrink a little bit. And so I don't talk a lot about weight. I don't talk a lot about what I saw on the scale. And so my practice is to talk about how your body works and how your body can function optimally. You can establish rapport with some families by talking about it as a chronic disease, about prevention of chronic diseases. And, we have a little health class and we describe how the bodies work. That is much more engaging with adolescents and children than talking about their weight.
I always start my visits with telling my patients that I'm not here to take care of a short-term problem. I try to understand what is important to them, and the visit needs to revolve around that. I want to make sure that you grow up to be the individual that you want to be, to achieve all your goals. I had an adolescent who wanted to be a bodybuilder. We have push-up competitions together, and that's what we work on. We do them together in the office, and that makes them really look forward to their visit. And I think that's really, really important. And that's unfortunately not the norm.
So given the promise of these new medications and the challenges around this problem, what's needed here?
I think in the U.S. that all families should have access to foods that we know are healthy for their growing infants and children. We know that families who participate in WIC, Women, Infant, and Children's programs, we know that participating in WIC reduces the risk of childhood obesity. So that means having access to food and nutrition for your children is preventative. This is a chronic disease that our environment has created, by and large. And so I think that we need policies that put kids first in order to support ways to increase public health of kids to reverse this.
I am worried, but optimistic at the same time. I'm worried because the rates of obesity are increasing. I'm worried because a lot of the children I see are going to go into their adulthood with chronic diseases. I'm worried about the increasing rates of chronic diseases that we're seeing. Like Dr. Hannon mentioned, we never used to see type 2 diabetes in the past, but now we're seeing type 2 diabetes. I'm seeing increased reflux, increased liver issues in children with obesity. I'm seeing increase of sleep apnea in children. I'm optimistic because I think we're having a better understanding of what might be causing this. We're having more tools in our arsenal to tackle the problem. The GLP-1s are only part of the story, and I'm hoping in the future we're going to have even more tools with precision medicine and personalized medicine to provide the right plan for each patient. And I think the understanding of obesity as a chronic disease is going to have us understand that we need long-term solutions to this problem.
Thank you both so very much.
Thanks for having me.
Thank you for having us, Rachel.
Dr. Awab Ali Ibrahim is a pediatric gastroenterologist at Massachusetts General Hospital. And Dr. Tamara Hannon is a pediatric endocrinologist and director of the Pediatric Diabetes Program at Riley Hospital for Children in Indiana. Next time, how much do we know about the spread of the bird flu?
It jumped into a new species. It spread wildly in that species. There's evidence of spread to people, although there isn't a lot of heavy-duty surveillance to know how much has it jumped species. That's why this is of concern.
That's next time on Intention to Treat from the New England Journal of Medicine. I'm Rachel Gottbaum.